So welcome to this Lyme Disease UK seminar. We're absolutely honoured to have Dr. Horowitz with us this evening. I want to say a massive thank you to you, Dr. Horowitz, for giving up your time for us. The UK community are really honoured to sit and listen to you. Just a bit of housekeeping before we start, as people come into the session, is that we will ask people to keep their videos off and their microphones off, because it's very distracting for somebody speaking if videos are on and off. So I just saw somebody turning some off, that, so really grateful. There are some moderators, some members of the team in the background who will turn videos and microphones on and off if they come on accidentally, just to keep, the pace going nicely. This session is being recorded, so you've got no need to take any notes. Just sit and listen to Dr. Horowitz. Everybody who's registered will get a recording by email, and there will be a Lyme Disease UK website piece with the recording and with Dr. Horowitz's slides made into a PDF. So no need to sit there scribbling away, trying to write down everything that he says. Yeah. And what else? They're all the main things. So we'll start off by a quick bio. I won't read your whole bio, otherwise I'll take it, because you've got a long bio. So Dr. Richard Horowitz is a board certified internist and medical director of the Hudson Valley Healing Arts Centre. An integrative medical centre specialises in the treatment of Lyme and other tick-borne diseases. He has treated over 13,000 Lyme and tick-borne disease patients in the last 30 years, and is one of the founding members and past president-elect of ILADS. So I'll just leave that there, because the whole bio is on the link to the session, and we'd rather hear you speak than me speak, I'm sure. So are you happy to share your screen?
Absolutely.
Right, so over to you, and we're all sitting in anticipation. I'll turn my video and everything off too, but if you need me to come back, just shout. I'm still here in the background.
Very good. Great. So good evening, everyone. It's a pleasure to be with you. I must tell you, I've been to the UK several times since I did my medical training in Europe, and I used to love coming over. And by the way, one of my favorite experiences, which you probably don't know, is my first year in medical school and second year, when it was stressful. I had done the Transcendental Meditation technique in Brussels, and I decided to do their advanced program, the TM City program. So the last stage was in Kent. And I ended up spending about a week in a castle in your countryside in Kent, doing meditation, where we were learning yogic flying and kind of jumping around like frogs in a big room. I thought Candid Camera was there. That's a whole separate story, not for today, but I just wanted to tell you, I've had some great experiences actually being there. So the talk I'm going to give for you today is the future of Lyme. And I've got some extremely good news for those of you suffering from chronic Lyme. I did get all of your questions. For those of you who want updates on kind of what's going on with treatment and kind of where this is going to go, what can we do with the UK guidelines, where I've only got 3 weeks allowed by NHS. I'm going to give you some ideas of where this is going based on some mistakes my patients have made over time. We'll talk a little bit also about the global health challenges, because I think many of you know I've just written a third book, Starseed Revolution. It's a climate change science fiction novel, which discusses actually the increase in Lyme and tick-borne environmental toxicities and kind of what's happening to the health of the planet if we don't all come together in a good way to make some changes. So I'll talk to you a little bit about some of the science of climate change and what we can all do with some solutions, so that I will give you hope both on the Lyme field and also in the climate. So we're going to discuss prevention, diagnosis, and treatment options today. The first overview I'll just give you a very quick overview of how acute COVID and long COVID and acute Lyme and chronic Lyme actually overlap with symptoms. So I will explain to you how you can tell the difference in very simple terms between the two. We'll talk a little bit about some of the new prevention methods that are coming up, both personal and environmental. Very simple ways of making a diagnosis. There are a lot of new technologies that are coming out. In fact, one just got published yesterday, which I did not have time to put in the slides, about antiphospholipid antibodies. It's an antibody that we've known about this for 30 years. You see a lot of autoantibody production in Lyme disease, like anti-myelin antibodies, anti-ganglioside antibodies, anti-thyroid antibodies, ANAs, rheumatoid factors, very common. But in this case, they found that antiphospholipid antibodies are produced in early disease before the ELISA, and antibodies may be produced, and it may show that the levels go down quickly with treatment. So it may be a marker of early Lyme and treatment success, apart from following some of the classic markers that we've been following. That's actually good news, and that just came out within the last 24 hours. I'm going to mainly focus today on some of the effective treatment options using biofilm and persister drugs using disulfiram and or dapsone together or alone. I'll show you those studies. We're going to talk a little bit about future options with persister drugs like azoxystrobin and hygromycin A. And finally, I'll finish off the talk with the role of climate change, which is increasing Lyme and tick-borne diseases. It's changing the kind of ticks that are in the environment. The ticks are coming out earlier. The diseases are starting to spread. And it's also increasing the number of environmental toxins that are now getting into people's bodies. My disclaimer and conflicts of interest is that I've had 2 books on Lyme. Why can't I get better? How can I get better? For which you get royalties. I just put out a new book, Starseed Revolution, The Awakening, through Permitted Press. I'm on the Zymogen Board of Advisors, have stock. I've received grants from Bay Area Lyme and the MSIDS Research Foundation, and especially that because I work for HHS and I presently work for the New York State Department of Health Tick-Borne Working Group. None of what I'm going to express to you today represents their views. These are my views solely. So COVID-19 as well as Lyme and co-infections have overlapping symptoms. In both diseases, we can get fever, chills, headaches, chest pain, cough, shortness of breath. Of course, cough and shortness of breath with Lyme most often is a co-infection with babesiosis. Fatigue, brain fog, neuropsych symptoms, anxiety, depression, psychosis. We're seeing them now in both COVID, and we've seen them, of course, in Lyme. The reason we're seeing them is both diseases are driven by inflammation. The virus is driving the inflammation in one sense, and really Burgdorferi co-infections are driving it in the other. But the reason they look the same is because we're seeing the exact same cytokines. When NF-kappa B, which is a switch inside the nucleus, gets turned on, you get it turned on with Lyme. It is turned on with COVID-19 when the virus attaches to ACE2 receptors on the cells. The cytokines that come out, TNF alpha, interleukin 1 beta, IL-1, IL-2, IL-6, IL-8, IL-10, IL-18, all of these cytokines are overlapping because when you turn on this switch, TNF alpha, those are the cytokines that come out and therefore cause similar symptoms: fatigue, headaches, brain fog, pain, etc. So when we talk about simple nutritional supplements, which was one of your questions for me today, the ways that we block NF-kappa B with Lyme and with COVID is using N-acetylcysteine, 600 milligrams twice a day. It's a precursor of glutathione. Alpha-lipoic acid, up to 600 milligrams twice a day because it regenerates intracellular glutathione. And it's a very potent antioxidant, both in water-soluble and fat-soluble. And finally, glutathione itself, which we published the first worldwide study showing that glutathione deficiency may be playing a role in COVID-19. And I essentially knew to use it because when I would give it to my Lyme patients with Herxheimer reactions, of course, they would get better. And the patients with babesiosis who would come in with shortness of breath, and I would give them a shot of glutathione IV, would say within minutes, their shortness of breath cleared. So that's how I knew to use glutathione in COVID-19. So we need to create a differential diagnosis. So how do you tell the difference just from a clinical perspective between the 2 diseases? Well, first of all, you can get pain, muscle pain, joint pain, nerve pain with COVID-19, but it doesn't migrate. Migratory pain is the hallmark of Lyme. And most of the time with acute or chronic COVID, the symptoms are pretty much constant, but with Lyme, they tend to come and go. They get worse with women around their menstrual cycle because as the estrogen goes down, the bugs tend to come out and it gets worse. If you give an antibiotic for someone who has Lyme, you're usually going to see an improvement because you're lowering down the load of the bacteria, or a Herxheimer reaction, where you're releasing cytokines because you're basically getting an inflammatory response. You're not normally going to see that with COVID-19 unless you've got COVID-19 pneumonia or something else that requires an antibiotic. So, and keep in mind that both diseases can be present. You can, of course, get acute Lyme and get a case of acute COVID. You could have chronic Lyme and get COVID and go on to become someone who has long hauler, where your underlying Lyme symptoms are going to be worse because you're now having extra cytokine production. And as I'll show you as I go through the presentation, the 16-point MSIDS factors that we've been evaluating for years, that in both of my books, and the main book I would advise you to read if most of you haven't read it is the last one, which is How Can I Get Better? An action plan for treating resistant Lyme and chronic disease. That goes through the 16 points in detail. And by the way, we're finding exactly the same points in COVID-19. They're finding POTS dysautonomia. People stand up, they get dizzy, they pass out, they feel fatigued, they get anxious, they get palpitations, they get brain fog. Those are all symptoms of POTS in Lyme, and they're getting it with COVID because of an autonomic neuropathy from inflammation, right? Because we have the 3 I's: infection, inflammation, and immune dysfunction, both in Lyme and in COVID. We're seeing mitochondrial dysfunction because you're getting a lot of free radical oxidative stress. We're seeing reactivation and infections in COVID. They now know if you had a positive COVID PCR in the blood and you get a reactivation of Epstein-Barr with a history of autoimmunity and diabetes, those are the 4 main factors that are factors in long COVID. We see the same things with Lyme if you've had underlying autoimmunity, so diabetes, underlying symptoms. So the importance of antioxidants and glutathione in both diseases is really important because these 3 I's, infection, immune dysfunction, and inflammation, is seen in both diseases. We know that there's 140 times more glutathione in lung tissue than in any other place in your body. So if you've used up all of your glutathione because you're dealing with Lyme, or you're getting exposure to pesticides and environmental toxins, which all of us are at this point. We're exposed to hundreds of environmental toxins, even up to thousands every day. You're going to use up your glutathione, which is your primary way that your body deals with these foreign-based chemicals to make them water soluble so you can get rid of them in the body. Well, if you use up your glutathione and then you get COVID, you're not going to have enough antioxidants to be dealing with the oxidative stress in the lungs. And that's why you're going to get COVID lungs with scarring and with some of the problems they're now seeing with air trapping going forward. So published case studies in COVID-19 have shown benefit using glutathione. And there is scientific evidence of using nutritional support. That would be an hour presentation alone. You can look up some of the studies that I've done on it, and you'll go on my website. I'll show it to you in a second. You can look at those studies. But things like NAC, alpha-lipoic acid, glutathione, which block NF-kappa B, using curcumin, turmeric, and broccoli seed extract, sulforaphane, glucosinolate, maybe with a green tea extract and resveratrol. Those are what are called NRF2 stimulators. That is another pathway to lower inflammation in Lyme, also works with COVID. And finally, there's a third pathway called the NLRP3 inflammasomes. In COVID, you can stop it with melatonin, just 1 milligram at night. And with Lyme patients don't fall asleep. They have a form of a circadian rhythm disorder called DSPS, which is delayed sleep phase syndrome, and also low-dose melatonin can be helpful. So again, something you can add on for both diseases with a little bit of zinc, because macrophages are activated in Lyme and in COVID with ongoing inflammation. Zinc helps to regulate those macrophages from not overdoing the amount of inflammation that's coming out. Beta-glucan, which is a way to stimulate your natural killer cells and T cells to fight intracellular infections, a Th1 response, and that's where most of your Lyme bugs and co-infections are hiding, are intracellular. That same Th1 response is also necessary for viruses like COVID-19. So again, beta-glucan and transfer factors. We use them in Lyme, can also be useful in COVID-19. So this is the first article we published on glutathione in the world literature. It's been cited over 150 times, more than any Lyme article I've ever published. I can't believe that has actually happened, but it is. So if you want to see the support that I have been on, my wife has been on, and in fact, I've been taking these for years, way before COVID, because many of you do know my story. All of my family has died of cancer. And I'm an Ashkenazi Jew. I came from my grandparents. Some of them came from Russia. Some of them came from Poland. And they all died of different forms of cancer. Now, when they came to the US, they grew up in Brooklyn. Many of them were smokers, but also exposed to environmental toxins. But I've been on many of these supplements because we know as you age, inflammation is the #1 cause of all acute and chronic disease. And we know also that it is ultimately inflammation and all these environmental toxins that are also helping to drive cancer, apart from, of course, genetic factors and viruses and other things that, of course, have been associated with cancer in the body. So you can find this on cangetbetter.com. Just go under the COVID tab. You can look up COVID treatment. You could look up prevention. You'll also see randomized trials that we were planning on doing. One will probably take place at the University of California, Irvine. So I won't need to go through this in detail, but all the scientific references for this is in, when you read the randomized trials, you'll find all the references. So now let's go on to Lyme disease. Someone in the background, if you could please mute yourself, that would be appreciated. So the main point I'm going to talk about this evening for you is, up until about 7 years ago, we didn't know about biofilms and persister forms for Lyme and their importance. When I discovered Flagyl metronidazole about 20 or 25 years ago and presented it at one of the LDF conferences in New York City back in like the year 2000, I didn't know why Flagyl was working, and Dr. Borison from Norway discovered that it hits these cystic forms, otherwise known as L forms, S forms, cell wall deficient forms, round body forms. We didn't know that those forms existed and that they would come back after treatment. I thought that was the main reason Lyme was persisting. Now we found out about 7 years ago through research from Stanford and Johns Hopkins and Eva Shoppe's group from the University of New Haven and Kim Lewis that we've got these biofilms and persister forms. And the way to think about biofilms is that the reason you have to go to the dentist a couple of times a year to get the plaque taken off of your teeth is that there are bacteria under the plaque. The plaque is a biofilm. And if you don't get to it and you get gingivitis, that gingivitis will not only destroy your teeth and your gums, but it's now even been associated as a risk factor for Alzheimer's because they are finding those bacteria, Porphyromonas gingivalis and others, in the brains of Alzheimer's patients, along with, by the way, Borrelia burgdorferi, herpes virus 1 and 2, herpes virus 6 and 7, pesticides from the environment. All of these things are under biofilms where we're making beta amyloid and tau while your immune system is trying to get rid of these things. So it really was a breakthrough. And when I heard Johns Hopkins researchers talk about biofilms and persisters, it wasn't that I didn't know that Lyme persisted, but I thought about it in terms of, oh, you mean Lyme is like Mycobacterium tuberculosis, a slow growing intracellular bacteria that's very difficult to kill. That's called a persister bacteria like Mycobacterium leprae. So I went to the medical literature. I had used these Mycobacterium drugs 30 years ago in my internal medicine residency at Mount Sinai, New York. And I really was jonesing for years to use things like pyrazinamide and rifampin we already were using, but I had never used dapsone. And when I read about the qualities of dapsone had excellent penetration into the central nervous system, something you need for Lyme disease. It's anti-inflammatory. I just told you that all the reason that Lyme patients and COVID patients get sick is from inflammation. It has anti-malarial effects. Well, most of my patients have parasites like Babesia that are overlapping, and it is a persister drug. It hits these dormant persisters to kill them. So it has 4 separate qualities that make it a perfect drug. So I knew that rifampin and dapsone had been used for years to cure leprosy, a persister drug. All I did was add doxycycline to it and then start to do studies. And lo and behold, it ended up working for patients. And I'll talk to you a little bit about some of those studies that we published in the medical literature. So the main one that I'll focus on with some new research is the double dose dapsone combination therapy. One person had asked me about this, about the updates. And essentially, it's an 8-week protocol, which has roughly about a 50% success rate. It doesn't matter whether you've been sick for 10 years, 20 years, or 30 years. And this is the key. If you don't have active Babesia, and especially Bartonella is really the kicker that is stopping people from going into remission from this protocol. But if you have addressed all of the 16-point MSIDS factors, like you have POTS dysautonomia, you're on salts, you're on fluids, you're on midodrine, your blood pressure is great. You checked your adrenals with a DHEA cortisol salivary test. Your adrenals were low, you brought it up. Your sex hormones were low, you brought those up. You have a certain amount of autoimmunity. You're dealing with that with, let's say, Plaquenil and certain nutritional supplements that we might use. So as long as the MSIDS variables are dealt with, then dapsone combination therapy will work if you don't have active Bartonella. And as I'll show you in this presentation towards the end, one of my patients recently made a mistake, just the same way I learned about double dose dapsone. And this person going into the 2nd month of double dose dapsone accidentally took a quadruple dose. And from my opinion, this is almost like God is whispering in their ears and going, make a mistake. Horowitz is going to notice and he's going to use it to help you all. And this person only got done with 4 days going into the second month. She was sick for about 15 years. She's now going on 1 year in full remission without one symptom. She never actually did 8 weeks. She only did 4 weeks and 4 days. And the kicker was, it was the higher dose of the quadruple dapsone. So I'll show you a little bit later on where I think this is going to go, because ultimately what this means for all of you is I now have about 40 or 45 people I've tried this on. And some of the people who've had double dose dapsone or had active BART, and I need to go through my patients' charts, which some of them is like 12 volumes. I need to see how many of these have positive Bartonella fishes, but I think a lot of them did. And many of them with 1 8-day pulse going on 3 or 4 8-day pulses. The guesstimate I'm going to give you right now is 50% of them are saying, oh my God, layers of the illness are coming off and I'm so much better. What is this telling me? It's not about the length of time you have to take these treatments. It's about the dosing of these persister drugs high enough while opening up the biofilms to get these persister bacteria so they don't keep coming back. So I was mentioning to you earlier that oxidative stress and inflammation is underlying all acute and chronic illness. So you'll notice whether it's Alzheimer's or Parkinson's or heart attacks or asthma, rheumatoid arthritis, it's all from free radicals, oxidative stress. So how are we going to lower inflammation, knowing that inflammation is responsible for all your symptoms in chronic Lyme and also again in COVID? Well, again, you're going to block these switches in the nucleus, NF-kappa B, NAC, alpha lipoic acid, glutathione. You're going to activate the NRF2 pathway with antioxidants and phytochemicals, curcumin, turmeric, green tea, resveratrol, and sulforaphane glucosinolate. You're going to block activation of glial cells in the brain using low-dose naltrexone. It's block NF-kappa B and also toll-like receptor 4 signaling, also getting your immune system to go from a Th2 antibody to a Th1 intracellular response, which is what you need for some of these intracellular bacteria. You're going to do an anti-inflammatory diet. And for those of you who ask me questions about your gut and how you can heal your gut and what you can do to support your gut, the fact is that a lot of the Lyme patients who come to see me have leaky gut. They have multiple food allergies. They have histamine sensitivity. They have mast cell activation. They have SIBO with small intestinal bacterial overgrowth. You need to be checked for all of these things because it's like rivers of inflammation. If you're a Lyme patient who says, I have this chronic fatigue and chronic headaches and chronic joint, muscle, and nerve pain, and my brain fog's all together and I can't fall asleep and I'm anxious, and it's just not going away, the problem is if the inflammation is not just coming from Lyme and not just coming from active Babesia and Bartonella, but it's coming from your gut because you're eating the wrong foods and you're secreting histamine with mast cell activation, those cytokines are going to be the exact same cytokines you're going to get with Lyme, and therefore it's like putting gasoline on the fire. So you should be on a Mediterranean style diet, increasing your omega-3s. Just if you're going to do a lot of fish, make sure it's a mercury-free fish oil. You're going to decrease a lot of your omega-6. You can certainly do pumpkin seeds as a good form of omega-6. But you're going to avoid your allergic and sensitive foods. And for most people who've never tried it, it's off gluten, it's off wheat, it's off dairy, it's off sugar. You want an easy way of doing it, just start cutting out those things. And if it's not enough, you go after the big ones after that, like eggs, shellfish, etc. But don't just do an IgE food panel. You've got to do an IgG26 delayed hypersensitivity food panel. And a lot of the functional medicine laboratories will do that. Number 4, you need to replace your minerals. Why? Because you use up all of your minerals in detoxification of all these environmental chemicals and when you're having herxes. Also, as I will show you towards the end of the presentation, when I talk to you about one of the solutions for climate change, which is regenerative agriculture, if we do 60 more farming cycles right now, there will literally be no nutrition left in our food because we're depleting the soils tremendously. So the food you're eating now compared to 50 years ago, thinking you're eating a healthy diet with fruits and vegetables, you're getting about 40 to 50% less nutrition. So I take a multivitamin supplement. The one I use is called MinRx, but it's got like 400 milligrams of magnesium and a little bit of calcium, but it's also got copper and it's got 30 milligrams of zinc. I'm getting all my trace minerals in because I don't regularly take a multivitamin, and I know that I need these extra minerals, especially when you're dealing with extra detoxification. Number 5, you need to get proper sleep. Lyme patients don't sleep. They can't fall asleep. they keep waking up in the middle of the night, or they have hypersomnolence, they sleep for 16 hours and they're still very tired. So again, this is DSPS. So if you don't get to sleep, one of these inflammatory cytokines called interleukin-6 is not going to shut off. So just like if you don't have your gut in order and you're eating the wrong foods because you're allergic to them, or you have leaky gut and mast cell, it's the same problem if you're not sleeping. You could do all the persister drugs and biofilm treatments you want, you're just not going to get better. The sixth is you've got to treat the infections. And a lot of these means dealing with your co-infections. Big ones are, Babesia bartonella. And we'll talk about, of course, the persisters and biofilms in just a second. But you've got to keep detoxing. Detox, detox, detox. It's essential to feel well while you're doing these type of protocols because amount of the inflammation and the Herxheimer reactions that results. And you've got to balance the hormones, as I talked about. Usually it's the adrenals and the sex hormones, sometimes the thyroids. You've got to repair the microbiome of the gut. One of the questions for me was, how do we support the gut? And, one of the most important probiotics is Saccharomyces boulardii. It's a type of healthy yeast that stops you from getting Clostridium difficile antibiotic-associated diarrhea. And I don't even get one case a year at this point in the 13,000 plus patients I've treated by using certain probiotics. But we use over 200 billion of these different strains of bifidobacterium, different Acidophilus. I use Theralac, Orthobiotic, Probiomax from Zymogen. There's a lot of good brands. So, just speak to your functional medicine doc about what's out there. And I have some suggestions in the back of how can I get better. You've got to heal the damage to the body. About a third of the Lyme patients have mitochondrial dysfunction. So that means that if you don't do things like NT factors, glycosylated phospholipids, CoQ10, acetyl L-carnitine, NADH, you have to do that after double-dose dapsone combination therapy in any treatment you're doing, because the mitochondria will get damaged just from living on this planet, from all the free radicals, but also sometimes from the treatment. Some of the patients, after they do these protocols, will tell me they definitely feel better after mitochondrial regeneration. The other trick is clear them out for candida, for yeast. Yeast and candida can look like Lyme. Fatigue, headaches, joint pain, muscle pain, brain fog. It really does look like Lyme, except it doesn't come and go with good and bad days and migratory pain, and it's dependent on your diet, especially sugar. But know that you may need to be cleared out for candida at the end of your Lyme treatment. I would say probably 1 out of 10 of my Lyme patients will say, oh my God, doc, I feel great. It wasn't the Lyme, it was the candida. That's a big clue, by the way, when you re-listen to this talk, which I'm sure some of you are going to do. The 10th, and this is a really important one, is you've got to heal the damage to the mind and emotions. So about a third of my patients coming in, I describe as the walking wounded, which means that they have PTSD. They've gone from doctor to doctor who says it's all in their head. And of course, the joke I use for them when they come to see me is, well, those doctors were right. It is all in your head. You have spirochetes in your head. You have Bartonella in your head. You have neurotoxins in your head. But the other part of this thing about the trauma is that a lot of my patients have had emotional trauma. They've had physical trauma. And about a third of the women have admitted to me they've had sexual trauma. So if that kind of trauma has gotten into the body, it's almost as if your immune system, if you've not done the healing work, and this is really difficult healing work, but I tell you now, you must do this. And you can do it with EMDR. You can do it with grief counselors. There's many ways of doing and dealing with this type of trauma. Annie Hopper has a technique, the DNRS, dynamic neural retraining system, but you have to get in there and you have to reprogram and basically know that it's not your fault. There's nothing wrong with you. And you have to have basically love and compassion and self-compassion for ourselves. Many of us are really hard on ourselves. And especially when you've got a chronic illness like this, you can't be taken, my wife's Sicilian. So in her case, it would be, the dagger, which is mea culpa, right? I'm guilty. I have shame and guilt. And it's like, oh my God, give it up. It's like, it's the other person who did this. You're an innocent person and it's not your fault. And it's not exactly like my mom would say when I would have an emotional issue, like, get over it. It's like, that's really wise advice, Mom. Thanks. Get over it. It's not exactly that easy, but just know the emotional healing piece, really important. Please don't ignore it. It is not easy. You will cry your eyes out, but I guarantee you, you will be happy when you get to the end of the journey, because the healing journey from Lyme, it's multifactorial, it's multi-layered. This is not just about getting rid of a bacteria in your body. If you do this right, a lot of layers of illness and wellness will result just from addressing the 16-point MSIDS model, because you're going to be balancing a lot of things in the body that otherwise would not have been balanced. So I don't really need to spend a lot of time telling you about how bad the diagnostics are. There's problems with labs, with his lab variation. You've got all these different species of Borrelia that are called Borrelia sensu-lato. In Europe, you've got at least 16 of them, apart from the big ones like Abzelai, which causes acrodermatitis, chronic amyotrophic and neuroborreliosis by Borrelia guerini. There's a whole host also in the US. The IGeneX immunoblot does 8 of these different Borrelia sensu-lato species. If you have a way in the UK of getting an IGeneX, IgM, and IgG immunoblot, it's really going to help you because it's going to check the main European strains that you have, and it's much more reliable than any standard Western blot that's using 1 or 2 strains. We know the 2-tier testing is going to miss about half of the Lyme cases. We'll see if the antiphospholipid antibodies that just came out of Tufts will turn out to be useful or not. We know the 2-tier testing misses also about half of the patients. When we did a study about 3 years ago on our chronic Lyme patients of how many had EM rashes, it was not the 70, 80% you hear about, it was 20%. And part of also the reason we don't find antibodies is because they are circulating immune complexes, which take the antibodies out of the blood, they combine with antigens, and that's why you can't find them. Borrelia also will subvert a B cell response. B cell is how you make antibodies. So Nicole Baumkarth showed this years ago in mice, where the mice were not making IgG antibodies, they were making IgM antibodies. And that's why many of you with chronic Lyme, when you keep checking your IgM and IgG Western blots, you're going to notice that over 40% of the time, you have a CDC positive IgM Western blot because Borrelia shifted your B cells over to make more IgM than IgG, and those are not as efficient as getting rid of these chronic persistent bacteria. And of course, we know Borrelia has many ways of evading the immune system. The biofilms, though, is really one of the major ways. So you can't just use one strain of Lyme disease if you're going to test. And you've got to look at the 5 major bands on an immunoblot: 31, 34, 39, 83, 93, and OSPE 31, 34, 39, 83, 93, some of the really big ones. So it is a clinical diagnosis ultimately. And what I suggest is use the HMQ, the Horowitz MSIDS questionnaire that we published several years ago. It's the only validated questionnaire for early Lyme disease, and it still can be used for chronic Lyme to follow your symptoms. So, if you are going to do an ELISA as a test, at least do the C6 ELISA, which checks for, again, your 2 major strains in Europe, Abzelai guerini, apart from one of the ones sensu stricto that we see in the United States. But what you should know about the C6 ELISA is that it also overlaps relapsing fever Borrelia, Borrelia miyamotoi. So if you do get back a positive C6 ELISA, do not think necessarily, if your other Lyme tests are negative, that it's just Lyme. It could be that you have a bad case of relapsing fever, which can look like Lyme disease. So we do a panel approach in the United States. I might start with a C6 and an immunoblot, IgM, IgG. If the C6 is negative, I might go to an ELISA or an IFA. I really like FISH testing for Babesia and Bartonella, which again is through IGeneX Laboratories. T-Labs, which is run by Bob Mosiani, they now have a Bartonella test. That is a Bartonella FISH test that I have gotten back a couple of positives. Marna Erickson, who's an expert dermatologist who does confocal microscopy, she's doing some of that FISH testing and microscopy. It's really fascinating. But again, the key is you got to look for these bands, the 23 OSPC, 31, 34, 39, 83, 93. If you're using an immunoblot, not a Western blot, the only one that changes, by the way, with a Western blot is the 31 can be positive if you've had a viral infection like Epstein-Barr. So if you have a positive 31, it could be an autoimmune disease, it could be Epstein-Barr. The 31 is not specific for Lyme if you're dealing with a Western blot, but it is specific on an immunoblot. The 41 is never specific because it's flagellar protein. It's how the organism essentially moves through your tissues. So the Horowitz MSIDS questionnaire is a validated screening tool. Your doctors can use this to track the Lyme. We published this with researchers from the State University of New Paltz several years ago with Dr. Mariella Cetera and my very good friend, Phyllis Freeman. There's 4 parts of it, 38-item symptom checklist. initially borrowed from Dr. Boroscano. What we did is we scored it, which had not been done, to mild, moderate, severe, or by frequency. We then added in another section with likelihood of having Lyme with migratory pain, which is the hallmark of Lyme. You only see it in 7 different diseases. We added the healthy day scale from the CDC, and finally a common Lyme score. The key to the specific questionnaire is if you have a score over 63, it's 2 standard deviations above the mean. It means you have a very high likelihood of having Lyme, especially if migratory pain is present. Now, this is really important. If you go to your doctor and your doctor says to you, you don't have chronic Lyme. First of all, it doesn't exist, blah, 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 blah. And then you can provide them with 700 references, which some of them are in my book and on websites through iLads and others. You go to your doctor and you say, Doc, I've got migratory joint pain, migratory muscle pain, or I've got this tingling, numbness, burning, stabbing sensation that's moving around my body. And I know right now some of you are listening, shaking your heads up and going, oh yeah, he knows me. That is pathognomonic for Lyme disease. If your doctor were to do a search in the medical literature and go, well, what causes migratory pain? There's only 7 things if he does a medical search. And it's in this article that I published on the Horowitz MSIDS questionnaire. Acute rheumatic fever. Not likely you're going to come with an acute strep infection and just all of a sudden have it. Inflammatory bowel disease, if you're not walking in there with bloody diarrhea and fevers, it's going to be unusual. Gonococcal arthritis, it's going to be pretty obvious if you have gonococcal arthritis because of obviously the discharge, the purulent discharge. Hepatitis, pretty difficult to miss it if you're doing AST and ALT on the liver function panel in the hundreds to thousands. Reactive arthritis, Salmonella, Yersinia, Chlamydia, HLA-B27. Again, these are like the digits. When you look at them, you pretty much can't miss it because of these really big digits. They call them sausage digits that you get with reactive arthritis or Reiter syndrome. Lupus is probably the one you'd have to be the most careful with to overlap Lyme, but I got to tell you, it's not like a lot of lupus patients walk into my office. And there are markers that are specific for lupus, like double-stranded DNA and Smith antibody antigen. So, but migratory pain is really going to be the hallmark of Lyme. So if you look at the factors on the questionnaire, neuropathy is actually number 1, tingling, numbness, burning, stabbing, migratory, brain fog, memory, concentration problems, musculoskeletal pain, fatigue, dysautonomia, POTS, I stand up, I get dizzy, I feel like I'm going to pass out, I do pass out, I'm chronically tired with palpitations, with anxiety and brain fog. The symptoms of POTS overlap Lyme. You got to do sitting and standing blood pressures and pulses. It's described in How Can I Get Better? And in some. So you can see that it's been validated, this questionnaire. It has convergent and divergent construct validity. It has predictive validity, score more than 63, high probability of Lyme. Between 25 and 62, probable Lyme. 25 to 44, possible Lyme. If you're healthy, you're going to be below 24. And questions 1 and 22 in the questionnaire indicate you have babesia. That's day sweats, night sweats, shaking chills, fevers, unexplained cough, air hunger. So if you were to take the 16-point MSIDS model and just get it down into a shorter treatment course, it would be the 7-point action plan that is discussed in How Can I Get Better? Number 1, you use symptoms to drive diagnosis and treatment. It's not all about constantly retesting. If you still have sweats that come back after babesia testing and you've ruled out other causes of sweats, your babesia is still active. If you have migratory pain and you've ruled out the sources of migratory pain and it comes back after treatment, your Lyme is still active, okay? This is not rocket science. Number 2, you lower inflammation through all the pathways we talked about, but I'll show you in a second the multiple sources of where it's coming from, as we discussed, whether it's coming from Lyme, from co-infections like Babesia Bart, from the gut, from lack of sleep, from mineral deficiencies, from environmental toxins. The inflammation can be coming from multiple sources. Rule 3 is detoxification. Rule 4, as we talked about, repair the damage from mitochondrial dysfunction. Rule 5, make sure you got those hormones balanced. Take care of your microbiome of your gut. Get to sleep. Get the right diet in order. Keep a regular a wheelchair, then you need a physical therapist, occupational therapist to help you to get going. And finally, as we talked about, healing your emotional wounds. This slide is a major slide you always want to go back to. If you can't figure out why you're sick, this takes the 16-point MSIDS model and divides it into two categories. Where is the inflammation coming from? And what are the downstream effects of the inflammation? So again, what are your chronic infections? Lyme, Babesia, Bartonella. It could also be Q fever. It could be tularemia. It could be chronic viral infections like herpes virus 6, West Nile, flaviviruses, Epstein-Barr virus reactivation, which we do see from time to time. So there are a lot of other diseases that could be persistent. You got to take care of the dysbiosis, leaky gut food allergies, mast cell, and as I said, SIBO. Get them to sleep, take care of mold. Mold and heavy metals are the two big ones. So you can do serum, mercury, lead, arsenic, aluminum. In the USA, we can't just use six-hour urine DMSA challenges to chelate, but I guarantee you, you're all being exploded with heavy metals and mold. And we're finding mold now in about 80% of our chronic Lyme patients. As these floods are happening with the hurricanes that are getting more and more severe with the climate, there's a lot of mold damaged buildings. And mold toxicity, by the way, overlaps chronic Lyme, just like long hauler syndrome will overlap chronic Lyme. And again, the downstream effects we talked about: low testosterone, low adrenal function, POTS, mitochondrial, autoimmune phenomena. So the common denominators that we're talking about is that infections and toxins, leaky gut, food allergies, allergies from the environment, dysbiosis, nutritional deficiencies, insomnia, these are all going to drive inflammation. They're leading to autoimmune reactions with downstream effects, and they're creating inflammation through the same pathways of TNF alpha, down-regulating NRF2, up-regulating NLRP3 inflammasomes, as we talked about, apart from, for example, mast cell activation through histamine, leukotriene pathways, et cetera. But we also get neurotoxins like quinolinic acid. That's probably why a lot of my Lyme patients love taking glutathione. I give them 2 grams of glutathione, sometimes IV, but could be oral. And many of them, up to 70%, will say my brain fog is mildly, moderately, or significantly better, or their pain is better, their fatigue is better. A lot of this is probably pulling neurotoxins out and helping to lower inflammation. We definitely get autoimmunity from antibodies produced against these agents. As I said, these antiphospholipid antibodies is not new. We've known about these for Lyme for years. Maybe we'll be able to use it in a new way for diagnosis and following treatment. But you're seeing the same inflammatory pathway, whether you call it chronic Lyme or you call it an autoimmune disorder like rheumatoid arthritis or MS, which MS is probably a really big overlap. You got to be careful. If you've ever been diagnosed with MS because you have demyelination and white spots in your brain, and you've got myelin basic protein and oligoclonal bands on a spinal tap, be careful, because you can still get those things with chronic Lyme. It's the amount of myelin basic protein. It's the amount of oligoclonal bands. It's the amount of white spots on an MRI that's going to tell you. It is a little bit tricky sometimes. And as we talked about before, you can have 2 diseases at once. It doesn't have to be one or the other. But if you look at chronic fatigue, myalgic encephalomyelitis, fibromyalgia, environmental illness, autism, somebody asked me a question about autism spectrum disorder and overlapping with Lyme. Any of the kids that I have seen and I know about, apply the 16-point MSIDS model, you're going to find the same things in the autistic population: leaky gut, neurotoxins, propiononic acid is coming from the gut, kind of fogging them out. You're going to find heavy metals. You'll find chronic infections. Lyme has been showing up in European studies, helping some of these kids. So just go back to the 16-point MSIDS model. It's helpful in a lot of these different diseases. So I'm not going to spend all the time, but again, I think most of you know the MSIDS model. But again, it's just to remind you, under infections, there's bacterial infections, parasite viruses, but also candida mold, immune dysfunction, inflammation, all these chemicals getting in, allergies, nutritional enzyme deficiencies, mitochondrial dysfunction, psychological issues, neurological dysfunction, endocrine disorders, problems getting to sleep, POTS dysautonomia, issues with the gut, elevated liver functions, pain syndromes, and deconditioning. In all the years I've been doing this, which is over 30 years, I have never found anything in a chronically ill patient that does not fit some of the model that I just show you here today. So this is the map that you're going to work with your doctors. And by the way, I've called and spoken to your healthcare providers, I can always get on the phone for 10 minutes with a healthcare provider who needs some help. I've done it many times, even for patients in the UK. I'm happy to help, but you just have to have an open-minded physician who is willing to work with me. I think that's really what it comes down to. So here's some of the studies we're going to discuss is the first Precision Medicine 1 on patients on dapsone combination therapy, and Precision Medicine 2, which is the role of the MSIDS model in defining, diagnosis, and treating chronic Lyme disease, PTLDS, but also other chronic illnesses. And when we look at the patients who came in with Lyme, you'll notice that most of them had almost every MSIDS abnormality. And that's why you have to go through the 16-point model in detail. So the diagnostics are a problem. They're also a problem, by the way, with Babesia. If you've got Babesia microti and you don't check for WA1 Duncani or for divergens, which is in Europe, which can cause hemolytic anemia, you're going to miss babesiosis. And unless your level of parasitemia is over 5% in the blood, you're not going to pick it up on a blood smear. So you're going to miss Babesia. Bartonella has over 30 to 36 different species and subspecies. You can't just look for Henselae and Quintana. You got to look for Vinsoni subspecies, Bartonella elizabethae. That's where you need to use these other laboratories like IGeneX and T-Labs and Galaxy to be able to figure out whether you've got these different species. We know that all of these different infections can persist, but not just Lyme. Babesia persists, Bartonella persists, Mycoplasma persists, brucellosis can persist, so can tularemia, so can viruses. So we've got to look at all of these possibilities of these persistent infections. And again, the reason all of you are even on the line today is because you've got a dysfunctional healthcare system that is refusing to look at the science. And if you can get your NHS on the line, I am happy to give them a 1-hour talk with them, back and forth, doing a back and forth. I will challenge any one of your infectious disease doctors from the UK to do a back and forth with me on IDSA guidelines and why they don't work. I am happy to do this for you, but you got to find somebody who's willing to go toe to toe with me to do it. And honestly, I'm happy to help your NHS and to get them the guidelines if they really want to help you. But to stay stuck at this point after 40 years of this illness, it is a crime. It is a medical crime against humanity because essentially we have answers, and I'm going to show you the answers right now. And if they get some money invested in the studies I'm about to show you, I guarantee you 100% you will see the answers for this chronic disease. Here is where the treatment lies that helps. So these are just a couple of the studies that are showing persistence of Lyme borreliosis. When we did the study on double-dose dapsone on 200 patients, 14.5% were still positive by PCR in the blood. Many were Babesia positive by PCR or FISH. Bartonella was positive by PCR or FISH. Tularemia titers went up. Brucella reactivated with agglutinations that were positive. Mycoplasma species were positive despite years of intracellular therapy, and we saw viral reactivation. So it is the biofilms that are protecting the bacteria. And if you don't get to these biofilms and open them up, the minute you stop your herbs or your antibiotics, they're just going to come back. What they discovered years ago is the majority of the inflammation in the body is coming from these biofilm and persister forms. How do I know? Because if I primarily use doxy, rifampin, dapsone with or without disulfiram, with or without a macrolide, methylene blue, and pyrazinamide, that, by the way, is a Bartonella protocol for people who ask me about what are we doing for Bart these days. It's multiple intracellular drugs with persisters because Zithromax macrolides with methylene blue goes after Bartonella persisters. Bartonella has persisters just the way Borrelia burgdorferi has persisters. So in that protocol, with high enough doses of the persisters, we are starting to knock it back. And when we did the clinical study, first we showed it worked, and then we did a culture study to say, well, gee, if what I'm seeing in practice is working, can we prove that it actually works in culture? I do everything backwards, right? Most doctors do cultures first, say, oh, it works. Let's see if it works clinically. What did we find? So if you look at the top left on dapsone alone or doxy, these are the size of biofilms in untreated, in treated cultures after 72 hours. Go to the bottom and look at K and L on the bottom right. This is after 72 hours of doing doxy, rifampin, dapsone. You'll notice that the biofilms are much, much smaller. They're almost completely gone, and it's a speck when you added Zithromax. So what this study basically showed is dapsone alone or doxydapsone or doxyrifampin-dapsone or doxyrifampin-zithrodapsone. And the key here is, please take this in clearly, the more intracellular drugs and the higher the dose of the dapsone as a persister drug, the better people do when they have Lyme and associated co-infections like Bartonella. Then we published the double dose dapsone combination therapy, which was also looking at a lot of these patients that were sick for up to 3 decades. What did we find? 7 to 8 weeks of doxy, rifampin, and dapsone. And you can, the study, by the way, has the full protocol, exactly how you do it, so your doctors can do it. There's no magic here. I gave away the whole protocol so all of your doctors can use it. It was superior to low dose dapsone. My wife had failed. My wife used to love dapsone. Every time she would go on it, her symptoms would get better. Every time she stopped it, her symptoms would go away, would come back. Once she went to double dose dapsone and she did this 8-week protocol, she's now 3.5 years in remission, and it's never come back. So it did come back at every lower dose of dapsone. And what we're now finding is in these pulsed quadruple dapsone, in these short 8-day courses of higher dapsone, short course, some of these patients that have even failed double dose dapsone are now telling me that layers of their illness are coming off. So the key is it's not how much time you stay on these drugs. It's the dosing of the persisters and opening up the biofilms that's making the biggest difference. But as I mentioned to you earlier, the co-infections that are making the biggest difference in stopping people from getting well are Babesia and Bartonella. And if you go to the top right, and it says Bartonella fish, 7 patients out of 40 were positive, you'll notice none of them went into remission. But if they were Babesia fish positive, 6 out of 40, half of them went into remission. So Babesia wasn't the kicker that stopped remission in 50%. It was Bartonella. So in the past, we used to use a lot of penicillins and cephalosporins. I will tell you right now, I use no more IV, except if someone comes in with an EM rash and they failed oral doxycycline. I don't have to use IV drugs anymore in my practice. Great news. I don't use Flagyl anymore. I use Plaquenil for the cystic forms, round body forms. I use some grapefruit seed extract a little bit for it. Mainly what I'm finding is combining intracellular drugs, tetracyclines with rifampin or rifabutin, with macrolides, not so much with quinolones, but also with pyrazinamide, and using methylene blue with the Zithromax because of Bartonella. When we combine this with a persister drug like dapsone or dapsone and disulfiram, and the way I keep down the side effects of disulfiram, I never now go above 250 milligrams, is I use 2 persister drugs at once, and I find it looks like we're having superior efficacy. So if you look at disulfiram from Dr. Liegner's work, over a couple of years, whereas my 8-week protocol put about 50% of people in remission, his protocol, which took 6 weeks, on the average, it was 6 months to 16 months, was about a 37% long-term remission. But the problem is the side effects. 2/3 of the people had severe fatigue. They had psychiatric symptoms in 50%, peripheral neuropathy in like a quarter. So the problem is it's a very long-acting drug with a 14-day half-life. Dapsone's half-life is a little more than 24 hours. It's in and out of your system if you have side effects. And the high-dose 8-day pulse protocol I'm telling you about is not long enough to even get anemia from the dapsone. And you can control the methemoglobin with high-dose glutathione and high-dose methylene blue. So I feel like I'm actually coming close to a long-term remission, but ultimately we're going to need randomized trials. So, the Lyme group in the UK and worldwide Lyme groups, you got to hear me well. I really feel like I'm really close to finding the ultimate answer for this thing, but it is going to require many patients going through clinical studies with their doctors and collecting the data in randomized trials. But we're going to need to do it because I feel like I finally may be coming up with an answer, and it may even have an answer for Bart, but I'm not going to know until I review these 40 patients to see, because I do believe a lot of these patients were Bartonella fish positive. There's new things coming down the pike. Some of you asked about azlocillin. Some asked about hygromycin A, which is a soil-based organism, which does not destroy the microbiome. It's probably at least a year out since we're going to see anything on this, but it is going to be new persister drugs that are going to be coming along. But as I said, what you should see from our office based on this high-dose pulse dapsone protocol is that I should have something by the summertime, so you will actually be seeing a new protocol that your doctors can use. So now let me finish off just with climate change and ticks and some of the global health concerns that I want to tell you about, because this is going to affect you and your children and all future generations. Climate change is now causing the ticks to come out 3 weeks earlier. This comes from Rick Osfeldt at the Institute of Ecosystem Studies. And as our temperatures are going up, it's increasing the reproductive rate of the insects, ticks, mosquitoes, and fleas. So tick rates are going up every year. Last year in the US, it was about 500,000 cases, and I'm sure it probably was more. We're seeing more environmental toxicity from wildfire smoke. If you knew the kind of chemicals people are ingesting from wildfire smoke with plastics and all these chemicals, it's really horrible, because it's less than 2.5 parts per million. It's the same type of small particle pollution that's now been associated with Alzheimer's and neurocognitive dysfunction. And we're getting a lot of mold exposure, as I talked about. So we've seen more heat strokes, more heat-related illness, dehydration, more cardiorespiratory problems. And in the places where there was a wildfire and the ticks were 100% Ixodes ticks, when they look years later as to the tick population, they now find about 55% are Ixodes and 45% are dermatocenter, meaning now rickettsial species are going to get a lot worse. So humanity is running out of time. And this was just in the Washington Post about 3 weeks ago. This is from the IPCC report that came out literally one day before my new book, which I started writing 4 years ago. Humanity has a brief and rapidly closing window to avoid a hotter and deadly future. So, quote, in the hotter and more hellish world humans are creating, parts of the planet could become unbearable in the not so distant future. A panel of the world's foremost scientists warned in an exhaustive report on the escalating toll of climate change. Unhoused greenhouse gas emissions will raise sea levels by several feet. I'm talking, by the way, in the next 10 years, and I'll show you why. Increased droughts, heat, hunger, disaster, millions of climate refugees. We're in the middle of the early stages of a sixth extinction. You heard me correct. I will show you the science on it. I have many more slides on that, which I did not put in tonight because I didn't want to overwhelm you, but they're there if you wanted to take a look at them. And we're going to see more deaths from malnutrition, from heat and pollution. The reason it is speeding up is they're finding spiking methane emissions now that are causing climate change to get worse. So what's happening is permafrost in the Arctic. The Arctic is 2 to 5 times warmer than North America, which is heated up about 1.1 to 1.2 degrees centigrade. It's 2 to 5 times warmer in parts of the Arctic, which means that as the permafrost is melting, there are large amounts of methane that are being released. Methane heats the planet 30 to 80 times more efficiently than carbon dioxide over a shorter time frame. So as more methane is being produced, more permafrost is melting, which is heating up the planet, because as permafrost melts, more methane is released, which heats things up, which therefore causes more methane. And you're starting to talk about a feedback loop. And as this feedback loop starts to heat, you're going to start to see this go very, very quickly. So there are early stages of a sixth extinction rate. Scientists have showed that by the year 2040 to 2050, 25 to 33% of all species on this planet will be extinct. It's including pollinators. There are multiple states in the United States where the bumblebee population is completely gone, multiple insects, fish, and certain mammals, and again, from man-made carbon methane pollution. This is one of several articles I just needed to show you about the fact that we're entering into the sixth mass extinction event because biodiversity is starting to go down. Biodiversity is essential to live on this planet. If we don't have the right ecosystem balance with insects and fish and mammals, the ecosystem is not going to survive. So we have records of extinction for reptiles, amphibians, fishes that go back to the early parts of the 20th century. And what the United Nations has found is that the extinction rates are rising by a factor of 1,000 above natural rates. We're losing 150 species a day. We're losing between 18,000 and 55,000 species per year. So we're in a really, really serious situation with the ecosystem. And as climate change keeps going on, even though none of us want to see more Lyme, it's hastening infectious disease spread worldwide. So since the 1990s, the warmer climate has now shortened winters. Lyme spread is now expanding. We know that the tick vectors that spread Lyme and mosquito vectors that spread dengue fever, malaria, chikungunya, Zika, West Nile, they're all starting to spread worldwide. So prevention is more important than ever. If you are not in the habit of putting 20% picaridin on your skin, wearing permethrin-treated clothing, There will be something by the CDC in the near future called Nucatone. It's a grapefruit citrus smelling extract, very effective against ticks and mosquito. But they're also looking at prophylactic exposure with anti-OspA monoclonal antibodies, same kind of thing you saw for COVID that was effective, which may prevent people from getting Lyme. They're looking in the US at bait boxes, bait vaccines, so that if a tick hatches onto a mouse, instead of getting live spirochetes, the spirochetes will be killed because there will be antibodies inside the mice. They're looking at fungus, Wolbachia, CRISPR, for basically starting to genetically transform some of these ticks and mosquitoes. So there's a lot of different things that are in the pike. And of course, the OSC and the Valneva vaccine, which is being evaluated in Europe. But you have to be clear at this point that the climate change report that literally just came out a couple of weeks ago is telling us we're almost out of time. And it's telling us we're going to hit at least 2 degrees centigrade by the end of this century. And it could even be 4 degrees if we don't get our act together. And you know, in the UK, the last time the oceans were at their peak was at Dover Cliffs when they were about 400 feet higher. So it's not that the oceans have not been hundreds of feet higher in the past. And I want to point out that in the Pliocene era, which was several million years ago, the carbon dioxide content was at least 420 parts per million. Would you like to know where our CO2 levels are right now? 420 parts per million. So during the Pliocene era, seas were 30 to 80 feet higher than they are right now. We are at that carbon dioxide level right now. It is not a question of whether it's going to happen. It's a question of if it's going to happen. And the thing that's about to speed it up in the next 3 to 5 years, and this is where I need you to put on all of your thinking caps, is there's a big old glacier in West Antarctica called the Thwaites Glacier. It's about the size of Florida. They expected the ice shelf, which is holding it in place, is supposed to crack and collapse in the next 3 to 5 years. If that happens, they're expecting global sea levels to rise by at least 2 to 3 feet. So if that happens, it's like taking the cork off of a bottle, where not only is this big glacier now sitting in a warming ocean, raising sea level, but there's nothing to stop the glacial melt happening from behind once this cork is gone. So the consequences of a 2-degree rise will be massive glacial melting, flooding in low-lying areas, destruction of farmland with food shortages, tens of millions of climate refugees being displaced, and the hardest hit are going to be the disadvantaged and poor nations that had nothing to do with this in the first place, because it's obviously the industrialized nations that are responsible, but also indigenous peoples who have already suffered tremendously, and local communities dependent on agriculture. The health risks: heat-related morbidity and mortality with strokes, ozone-related mortality, more mold toxins, wildfire smoke with toxins and small particle pollution, malnutrition as the food supply goes down. Proper nutrition will be a problem, more vector-borne diseases from mosquitoes, fleas, and ticks, and a risk of new viral, bacterial, and fungal diseases, because as the permafrost melt, it's releasing bacteria, viruses, and fungus that humanity has never had exposure. So if you're not sick and tired enough of 2.5 years of a pandemic, just to give you more good news, there are bacteria and viruses and fungi that are live inside the melting permafrost that are being released. And scientists have shown that they can get into the stratosphere at 60,000 feet and be traveled to North America. And these are bacteria, viruses, and fungi that humanity has no natural immunity. And excuse my sarcasm, but we're not going to make a messenger RNA vaccine every time a new bacteria comes and says, oh, we have no natural immunity. That's a whole nother presentation. So when I started writing my book 4 years ago, when kids were coming in with climate grief, as they get over Lyme disease from double dose dapsone, and I asked them, what are you going to do with your life? You're going to go to college? You're going to go get a job? And they said, no. And I said, why? They said, well, the world's going to end. Why should I bother going to college or getting a job? And the universe, when it wants me to know something, it usually does what I'll call the law of synchronicity, where it keeps knocking on the door until I get it. Kids literally will come in every day or every right responded, why would anybody book on the climate by a Lyme doctor? To which they then said, well, no, not a regular book, write a science fiction climate change book that's humorous, that will pull people in, teach them science, and give them hope. So all the solutions for our climate, I've researched it now for years, are in here, including, by the way, some very secret, precious meditation instructions from my 40 years of studying with Tibetan Buddhist lamas that will help with climate grief, that will help with a lot of the anxiety that people have, and may even help with quantum physical principles, shifting reality, and what I like to call the 1% global climate solution. So the three-part solution that I have right now that is in the book, and please, you can go on my website, starseed-revolution.com. We need to transform planetary health by transformation of social, political, medical, energy, and economic structures. We need to transform personal health through the 3 I's that I talked to you about with personalized medicine. And then number 3, we need to transform the world through certain quantum physical principles. So the first, to get back the world in balance, we obviously need efficient energy production, geoengineering of the Arctic, because if this glacier falls in the next 3 to 5 years, we're all in trouble. And there is a way to cool down the Arctic to stop this from happening. We need to change over how we do agricultural practices. It's called regenerative agriculture. Every time we turn over the soil, we release carbon dioxide, and we're not replenishing the soil with the right nutrients. Therefore, we need to change our full way we do agricultural practices, including, by the way, putting nitrates in the soil, because that releases nitric oxide, which is 300 times more potent than carbon dioxide and even more potent than methane. And nitric oxide production is now also going up. We also need regenerative development and changes in economic, political, legal, social, industrial, with cultural infrastructure solutions. It's not that solutions don't exist, we just need to institute them. The one that needs to be instituted from Stanford University and Mark Jacobson, which is in Starseed Revolution, is a roadmap for 139 countries to become energy neutral. And now with the war that's going on in Ukraine, this is perfect, because then the geopolitical tensions, a lot of this is dependent, of course, upon Russian oil and gas. So if you were to become energy independent, which is now possible, it's just going to require everybody in the next couple of years starting to make this transformation. But the reason I'm going to highlight geoengineering, and this is really one of the most important things I'm going to tell you, because if I was a seer in the future and someone went back in time and said, there was something you needed to know to stop one of the largest disasters that will happen to the earth in the next several years, and you went, well, what is that? It is geoengineering to stop the permafrost melting before the Thwaites Glacier collapses. There are ways of doing this, because in prior volcanoes, like the Philippines volcano in 1991, it cooled the planet by a half a degree centigrade for years by basically putting sulfates in the atmosphere and blocking sunlight. So we can do sulfate seeding, mimicking volcanoes, cloud brightening, which stops UV radiation from hitting the surface, solar reflectors by Harvard. There's lots of ways of cooling down the Arctic, and we need to do it now before this glacier collapses and goes into the ocean. I've talked to you about the 3 I's and the MSIDS model. Right now, 18% of the GDP in the United States is for healthcare, and we're like, I think 29th or 30th in the world. We're not doing that well. We name a disease and we throw drugs at it instead of prevention, instead of trying to figure out early on how to stop this from happening. The model needs to be shifted from a prevention model where the insurance companies can get involved and make money off prevention, just like they do off illness. But there's got to be a prevention piece and a personalized precision medicine model. You cannot do chronic illness, which at this point is 70% of the deaths and 86% of the healthcare costs. So the whole healthcare system needs to be changed. Please get this presentation to somebody at NHS, because it's going to have to happen over time. And the third solution is transforming planetary health through quantum physical principles. I learned through studying with these Tibetan Buddhist masters specific techniques of working with the mind that not only are extremely effective in calming the mind and learning how to get into very deep alpha states and theta and delta, very deep states of meditation and calming the body for personal health and emotional health, but ways of also working on a deep level of how to transform with quantum physical principles internal reality with external. And I don't have time to go into it, but believe it or not, there are scientific studies on meditators using the type of meditation technique that I actually learned in Kent, England, that I was referring to earlier. There are studies by Harvard and Benson that they did these studies on these meditators in certain parts of the world, and it actually changed social variables in the environment where things got tremendously better. There is a direct relationship between the mind and external reality. So in conclusion, COVID-19 and Lyme both show similar symptoms because of the three I's. Their clinical diagnoses, there's a 30% false negative rate of antibody PCR in COVID, 45% in Lyme. Both Lyme and COVID cause chronic symptomatology. First screened with the Horowitz MSIDS model with the 16-point MSIDS map. And again, these newer persister medications and biofilm agents, for me, are the absolute path to go forward to help all of you who are sick while addressing all the abnormalities on the MSIDS model. I have seen miraculous transformations even in my most resistant. And most of you know, the only people left in my practice are the people who failed 30 doctors. The quadruple pulse dapsone with the double dose dapsone seems like it's even getting into some of those people. So stay tuned this summer when I get that next publication out there. Dapsone and disulfiram represent newer treatments using biofilm agent and persister drugs, right? Dapsone's about a 50% average with a 7 to 8 week protocol. Disulfiram about 37%, but I don't like the side effects at the higher level, which is why now I use lower dose of disulfiram and mix it with Dapsone. The side effects of Dapsone, they are easy to control. They really are not that bad, and methemoglobin can be controlled with methylene blue and with high dose glutathione. They, however, are ineffective against Babesia. One of you asked, how do we now deal with Babesia? And unfortunately, there is no easy cure, but I take drugs like Coartem, artemether-lumefantrine in 2-week rotations with Malarone, with Cryptolepis, with Artemisia. I rotate in my Babesia medications and herbs, and I usually find that I can knock down the load. And for Bartonella, it's a tetracycline with rifampin, with a macrolide, with methylene blue, with rifampin, with 1 or 2 persister drugs, and maybe this higher dose pulse that I'm telling you about. But until I go through all the charts and I find out how many actually had positive Bartonella fishes who said, doc, my neuropathy is getting better, doc, my resistant brain fog. By the way, one of these patients in the quadruple pulse dapsone was sick for, I think, about 30 years. He never knew what normal was. On his 3rd round of this protocol, 8-day protocols, he told me his brain fog was the best it has ever been. And that's somebody who's been sick for 3 decades. Every time he did this protocol, a layer of the illness came off. I mean, it's really amazing. And that's telling me, okay, this is the final path we've all been looking for, right? It's the clues to what is going to finally get us to a durable cure for this disease once and for all. But we are going to need to do randomized trials. And I am going to need your support and everyone's support to get these done because I'm busy trying to do a lot at this point for the climate because it's the greatest existential threat that mankind has ever faced. So I'm trying to help with randomized trials with COVID, with Lyme and the climate. So however you can help me to get some of these studies done would be appropriate. And finally, again, please educate yourself on the climate. And I would appreciate your support and everyone by getting the book. It's on Amazon. And I guarantee you will like it. There's a lot of Lyme jokes. Everybody needs a laugh, and you will learn about the climate and solutions and people who need hope, the solutions of what we need to do with the climate. They're on my website. They're in the book, but especially the meditative solutions. There's kind of some secret stuff in there. I can't give too much away, but I promise you, you will enjoy it. And please share this with anyone who has anxiety and grief. They really need to read this to understand that just as I'm giving you not false hope with Lyme today, there is true hope with Lyme. There is true hope with the climate. And I'm finish off there so we can take question and answers.
Hi, thank you very much. I'm back. You can see me back, yeah?
I can.
Yeah, thank you. That was pretty amazing. And I'm sure people are just absolutely blown away after listening to that. As I said at the beginning, everybody will receive a recording within the next few days of the whole event. So anything they've missed, you've given them an actual complete lecture that they can go back to. So that's really great. Thanks. There's about 1 million questions in the chat box, which if we stayed here all week, we wouldn't be able to answer. And I have some here. And obviously I did send you some. And like you said, you have covered a lot of those.
What, do you want me to just answer some of the other ones that maybe I didn't go through quickly?
Yeah, if I could just I know that the audience today is mainly people, will be mainly people who have been around the Lyme world a long time with chronic infections, but I would mind, if you don't mind, just asking you some questions that you might think are a bit basic, because we do have an online support group, and they're things that we're faced with every day with new people coming. So obviously you're aware, I know you're aware of the NHS guidelines. Yeah, no laughing. And so because we have people coming to us, many people in our community cannot afford to get private treatment. You know, they can't afford to access a knowledgeable doctor like yourself. So the guideline in our country is basically 3 weeks of doxycycline. And if you're still symptomatic and you've got a doctor who'll go along with you, then the guideline does say another 3 weeks of high dose amoxicillin. So many of our community, that's where they are. Okay. So if that's my protocol and I can't access anything else, what are the things I can do to get the best out of that protocol?
So, so first of all, and I don't mean to do this too much tongue in cheek, because I lived in Europe for 7 years doing medical school in Belgium. So I know that there's a tendency to go to pubs a lot and drink quite a bit. Disulfiram is for alcoholics. And there's a way to get on disulfiram without ever admitting that someone has chronic Lyme. I'm not saying make stuff up. I'm just saying if you happen to be drinking a little too much and want to get off and want to use a low dose of disulfiram, you may actually notice some help using disulfiram alone without any other treatments, because it's helpful. It's just you got to protect against the side effects. Ultimately, for me, for the NHS, what the NHS is going to need, you guys are going to need to do a clinical trial. And I will always put forth this, throw the gauntlet on the ground, which is if the NHS wants to put together in a hospital one treatment clinic that uses IDSA guidelines, 3 weeks of whatever you're doing, and another clinic that uses the Horowitz MSIDS 16-point model and these persister protocols, I am happy to speak to anybody in your country at NHS or otherwise about setting that up. And you and I both know where that clinical trial is going to go. We already know where the successes are going to lie, but it's probably the only way I'm going to be able to convince anyone that the guidelines that they're using are not working, because you're going to want hard science. Now, a lot of times universities and the governments like being the first, right? Their egos are involved in this, that we're going to be the first to prove something or other. Get them involved. You want to find the cure for Lyme? You want me to show you where the clues are? I gave you tonight the clues, which for me is, it's not just persister and biofilm drugs like dapsone, disulfiram, it's the dose. These pulse protocols are definitely showing that some of these patients with persistent symptoms are helping. I just don't know how far this goes. Like, I don't know if, 8-day pulses without any other treatment would do it for someone. I have no idea, but these are the kind of studies that people are going to have to do going forward. All I can do is lead you in the direction of what my clinical studies are showing and saying, hey, if I ruled the world and I had unlimited amounts of money and I could do every study in the world I would want to, I would be doing these clinical studies where, in one group, they do double dose dapsone. And in another group, they would have Bartonella, and they'd be playing with different protocols for Bartonella with different intracellulars. And in another, would be using for Bartonella and Babesia, these pulse protocols. And some would do certain number of pulses. Others would do more pulse. You'd have all of these different trials going on, because this is going on for 40 years with millions and millions of sick people. Except somebody's got to, have enough compassion, enough wisdom to say that we can't just ignore this, because if you look at the disability rates and what it's costing the governments across the world to be dealing with all of you disabled people, it would be much better money spent to just get these studies done. And I can point them in the right direction if I can just get somebody's, attention. And fortunately, because I work for HHS in the United States, at least I have some credentials that I can use. And I still work, by the way, I'm on the New York State Department of Health Tick-Borne Working Group right now. We don't meet all that often, but I'm working for them. So any way you want me to get me in touch with them to help with clinical studies in the UK to do this, I'm happy to do it.
Thank you. That would be great if we could magic up something. But really appreciate that. And on that same line, staying with the people who,
by the way, there's one other thing I could say on that. So let's say all you could do was 3 weeks.
Yeah.
Right. All you could do. So I'm not saying it would be easy to do, but you could theoretically, if you could get dapsone, and I don't know how easily you can get dapsone in the UK, because I know in parts of Europe and France, they were restricting it because it's a mycobacterium drug. And it is used for other things. I mean, they use it for acne, they use it for inflammatory bowel, they use it for other things. But the point being, if you could get a 3-week protocol of dapsone, it is possible by going almost directly on double dose dapsone for 3 weeks. You might want to do 100 for a day or two and then jump in, but you could do it. As I said, methylene blue and glutathione with high enough folic acid. We use leucovorin at this point, like 100 milligrams of leucovorin, and L-methylfolate, probably at least 60 milligrams when I do double dose dapsone. So people are on 160 milligrams of folic acid to stop the drop in the anemia, which is a folic acid induced anemia from dapsone. If you were to do a 3-week protocol and go straight on double dose dapsone, and no one's done this, by the way, but it could be done. I just actually had a doctor that I'm treating him and his family. And he's a surgeon and he wanted to get it over with. Now, his was a 4-week protocol, but close to 3 weeks. He did get better. I'm still waiting to see the results because he's about 5 weeks off the protocol. But I can tell you that you could even do 3 weeks of double dose dapsone. And if I can publish this study on quadruple pulse by the end of this year, you could finish the last 3 or 4 days of the protocol with quad dapsone. So you actually might be able to stay within the NHS guidelines, but you would need to get dapsone prescribed and rifampin prescribed to be able to do the protocol.
Unfortunately, neither come under the guideline, but I get completely what you're saying. So talking about your dapsone protocol, somebody here has said, where are we? I think somebody's quoted 50%, it must be one of your studies or something, 50% of people don't do as well on the dapsone protocol. And somebody's asking, if they're one of those people, where do you move forward from that?
They're well. I don't need to do any. So this is what I was saying before. The ones who are 50% success, they don't need to be retreated.
No, the ones who aren't successful.
Well, most of the time it's Bartonella. So in that case, that's why I need to publish this quadruple dose pulse dapsone, which is an 8-day protocol. It's basically 200 milligrams for 4 days and 400 milligrams for 4 days. And I think about half of the patients who did this, it's about 40 or 45 patients, they were Bartonella fish positive. These were patients that had chronic Bartonella that failed double dose dapsone. The problem is I just got back from vacation. I'm about to start going through these records. I will know the answer to this by the summer when this is published. But the answer for BART, I mentioned it, I'll repeat it for you. The answer for BART has persisters. The only BART persister protocol that's been published comes out of Hopkins. It's a macrolide and methylene blue. So when I combine doxycycline with rifampin with a macrolide with pyrazinamide, 4 intracellular drugs, you need to use multiple intracellular drugs to kill Bartonella. And you do it with methylene blue, and you do it with a persister drug like dapsone, or 2 persister drugs like dapsone and disulfiram. That's what I'm doing for these BART patients. There are a group of them that are getting better. The drug that has cured BART, but I will not use it because of the side effects, is gentamicin. I've used gentamicin on top of this protocol, and I have seen people go into long-term remission, but it's such an unpredictable drug because of the ototoxicity on the ears. I don't dare to use it until somebody finds an easier way to use it. Now, there was a study a couple of years ago that if you use essential oils like peppermint, you can lower the MIC, the minimal inhibitory concentration of gent, so it might be as effective at lower doses, but nobody's done a clinical study on this yet. Gent looks like it's a great drug for BART. It was published by Hopkins also, but too difficult to use because of the potential side effects. So BART requires biofilm agents. It requires multiple intracellular drugs. If it's Babesia, you just have to keep rotating the drugs, but it's usually BART from what I've seen, as long as you've addressed all the other abnormalities on the 16-point MSIDS model.
Okay. one of the teams pinged me some messages out of the chat box so that I don't have to sort of keep going in and out of it. So where are we? Hang on a minute, just get on my little phone. There was one about another sort of fairly basic question, but I think helpful to people. If people have, muscle joint pain, which obviously a lot of people do you recommend any physiotherapy?
Absolutely. There's no reason not to do it. You definitely can get physiotherapy. The only thing you have to be careful with it is that some of the people, when you do massage, you do other things, they actually flare up. And that usually means that they need lymphatic massage, they need lymphatic drainage, the detox pathways are clogged up. So, if they go for a massage or do PT and they feel worse, you got to look at mitochondrial dysfunction, the mitochondrium not be working. You have to look at adrenals. They may not have the adrenal support because they start pushing and their adrenals go down. But yes, it absolutely can be quite effective.
Oh, thank you. This one's obviously very topical at the moment, and you've covered it in your talk. But have you seen any significant differences in treatment responses with those that have also had COVID in addition to tick-borne illness?
The reason for me no is because, first of all, I'm still proud of these numbers. Not one of my patients in my practice has died in the last 2.5 years from COVID, not one. And the COVID protocol that is on my website, just go on cangetbetter.com, go under COVID, you'll see the prevention and treatment. I didn't spend a lot of time today, but I published 2 articles in the literature. I only showed you one, which is glutathione. The second one in Medical Hypothesis discussed ivermectin early on. There was a lot of ivermectin controversies. The fact is ivermectin is a very good drug. The only reason there was this medical controversy is because it was off patent from Merck, who is coming out with a new drug, which, by the way, failed. Pfizer's drug Paxlovid ended up being the one that had an 89% efficacy. But that is medical politics. That is not medical science. And shame on world governments around the world, except for India and a few other places that actually used ivermectin and showed that the death rates went all the way down. So, I don't see long haulers. None of my patients who had chronic Lyme who got COVID, they didn't become long haulers because I treated them with 0.2 milligrams of ivermectin once a day for 14 days with the protocol that you see on the Can Get Better website. But theoretically, right now, what's been identified with long COVID is the MSIDS model. It's Epstein-Barr reactivation or viruses, which we see in Lyme. It's mitochondrial. It's Pott's dysautonomia, right? It's autoimmunity. It's the same stuff we're seeing with Lyme. What a surprise. It's the 3 I's: infection, immune dysfunction, inflammation. One's from a virus, one's from a bacteria, but it's causing the same MSIDS abnormalities. So you just go look in the same places.
So do you think, obviously, because long COVID, the focus is on long COVID now, or COVID, long COVID, do you think in the long run that's going to help people with chronic Lyme because it's so similar?
Absolutely. There's not even a question, because the chronic fatigue fibro community, they've been dissed for years. Like, oh, come on, it's in your head, right? And Lyme, of course, chronic Lyme, oh, come on, it's in your head, right? Because the IDSA, they're the gods of the world and they know everything. And God forbid there should be hundreds of articles that contradict, their guidelines, which the NHS for some reason has adopted. Unbelievable. So yes, the point is that there's a problem here because there's a lot of science, right? If they would look at it, they would give them clues, right, at this point in time. So I think it's going to help tremendously because the long COVID community went through the same thing initially, like it's in your head, like, I beg your pardon, like they got COVID and now millions of people are sick and it's in their head. It's like, you have got to be kidding me. That's like, what, the earth is flat at this point? That's like ignoring all the science. It's like, don't you read medical literature? Of course, it's a real disease. And to deny it, right, at this point, is just, you're just not in touch with reality at this point. You're not keeping up with medical science.
Well, I don't know. Just as an aside to this, I was reading some information the other day, and unbelievably, I saw a funded study where some people with long COVID who were on the weightier side they'd been recruited into a study to see if their long COVID improved with prescription diet shakes. I mean, I just read it and thought,
well, so here's the thing. I mean, we're supposed to do a randomized controlled trial of glutathione deficiency at the University of California, Irvine. I have to actually fill out the FDA forms because I'm asking for N-acetylcysteine and glutathione. If it works, that they're going to be considered treatment regimens, which means it has to be considered like a drug, and it needs an IND, an investigation to drug. So even though I have this protocol that's gone through the UCI for a randomized trial, it's been approved, I have to fill out this FDA form. So the thing about all of this is, there are shakes that, for example, are whey-based protein shakes. Whey-based protein contains cysteine. Cysteine helps your body to make your glutathione. So if somebody said to me, I took a protein shake with whey-based proteins and I felt better with long COVID, well, that to me would say, oh, it might be glutathione deficiency, right? But until we actually do the study, we're not going to know.
True. One thing that's constantly on people's minds, and you have touched on testing, where do you see the potential for any new sort of testing that actually gives us a yes or no answer without any controversy at all? Is there one coming in the future, do you think?
Well, so one thing that I would do with the UK that Scotland did years ago, I don't know why they never repeated this. You should look at all the strains of Borrelia you have in England and then put them in a Western blot / immunoblot and have a country specific Western blot immunoblot. Now, of course, the problem is people travel around the world, so you could still get other species and strains from other countries. But when they did that in Scotland years ago, they actually found that the ability to find it on a Western blot was actually much improved. As long, again, as you're using immunoblots, which is recombinant DNA, right? So you can't get false positives from viruses. And as long as you know it's the major species that are in the UK, and you're looking for these Borrelia specific bands, the thing is if you're a patient who's got a chronic fatiguing musculoskeletal neuropsychiatric illness, and you've ruled out other things, and you have a 23, 31, 34, 39, or 83, 93, or a VLSC antibody, that means you've been exposed to a Borrelia species. Like there's no other way that could be positive. So, then if you look at the panel approach that I was discussing, maybe these antiphospholipid antibodies will be useful in early and in treatment, right? But there's a lot of methods, right, at this point. The fact is that what I learned in medical school in Europe is that it's still always a clinical diagnosis. It's what they teach you in med school is all diagnoses, there's 90%, the patient will give you the clinical history and tell you what's wrong. Migratory joint pain is the hallmark of Lyme, with symptoms coming and going, with good and bad days, worse in women around the menstrual cycle, better or worse with antibiotics, with these bands. It has a very specific clinical profile. And knowing that migratory pain is only present in 7 different diseases, it's not really rocket science as long as your doctors understand that, like, they're limited as far as what their differential diagnosis is with migratory pain. And by the way, they can't prove, if you go into a doctor's office and says, I have migratory pain, they can't prove you don't. So what are they going to do? Call you a liar? It's like, and then if they look up migratory pain, they're going to be forced to say, oh, Lyme is one of 7 things that causes it. You could just show them the article we published on the HMQ questionnaire. So again, it's still a clinical diagnosis. Everybody keeps talking about test after test after test. I have never had a problem in 35 years making this diagnosis. Never. I'm a clinician. Come on, folks. It's like, get back to the roots of medicine. All of these other things are great, but it still is a clinical diagnosis. Could you just pop over here and we could adopt you for a few months? Would that be okay? You want to pay for my expenses to do it? Happy to do it. You may know this from my having lived in Europe. I love Europe. I would have lived in Europe if the weather wasn't so bad. I just couldn't take the weather. It was killing me. It's even worse in England. In the UK, I should say, shouldn't I? Anyway, we're on at 20 to 9 now in the UK time, and we've been doing this seminar much longer than we normally do, and it's been amazing. But I'll tie it up by one question that I always ask any of our guests at the end of a seminar, because people do come to us desperate for advice.
And I've already explained that, a great majority of them can't access the things perhaps they would like to access. But one question from you, what would you say to people who've got no hope at all? They think they'll never get out of this cycle of illness. What words would you say to them?
Well, see, this is really, I started off my talk telling you that there was hope for both Lyme and the climate, and I'll repeat it to you again. One thing about coming through the way I do is, and this is the joke that's in my book, Starseed Revolution, I'm half Arcturian, half Jewish DNA in this book. I have no filter between my brain and my mouth, so I don't actually know how to lie. I can only tell you the truth. I promise you, the persister drugs and biofilm agents and the higher dose of the persister drugs like dapsone are absolutely killing it with this disease as long as your MSIDS is taken care of. And it's the same thing with the climate solutions I've given you. This isn't false hope. This is real. But the next step to prove it, and by the way, not to tell you how to do this, but I think you know this, there are European patients who will come over or go to Germany. And in fact, I think most of them do go to Germany, and they get some of these drugs that I'm telling you about, like rifampin and PCA and dapsone. They get it through certain clinics in Augsburg, Germany, and other places if they don't want to fly over to the US. But some people can get these drugs in other countries and use them there with an open-minded UK physician, right? Or physician in Germany or someplace else that is overseeing the treatment. Now, again, I can get on the phone. I've done this before for UK physicians. You've got an open-minded UK physician who's not worried about their license, who's courageous and says, I see Horowitz's published studies and I'll wait for the quadruple dapsone this summer, but I'm willing to try 3 weeks of this protocol. I can't give it to you, but oh my God, you got it from Germany or whatever. I'm willing to oversee the treatment. There's still a shot with what I told you, staying within the 3-week NHS guidelines. I don't know that 3 weeks is going to be enough for the persisters based on what I know, but I know that it's going to kick down the load enough that by the time you're off of it, yeah, you're going to notice a difference. Your health will be better. There'll be a layer of your illness most likely that will be taken off. So there really is hope. I mean, I feel like I'm coming close to not just a 50% remission rate. We don't like using cure because for all I know, I'm knocking down the bugs by 99% and your immune system is handling like the 1% that's left. But now that I've seen the results of this pulsed 8-day protocol with quadruple dapsone for 4 days, these resistant patients that I didn't know what to do with, there's a whole host of them that are getting better. So I am having more and more hope as time goes on. But the part that I need the Lyme community's help with, you're going to have to help me to get some of these studies done because I've been doing this for, over 30 years and I'm always happy to help. But to try and run a randomized trial through the University of California for COVID and still run my medical practice and try and help with climate change and do this at the same time, I'm only one guy. You got to get me a whole group of people who are going to work together, but I'm happy to work with, motivated individuals as long as, of course, if they have a sense of humor. I mean, we all know that the Brits have one of the greatest sense of humor in the world, which hopefully I've replicated in Starseed Revolution. You'll let me know, by the way, if my humor matches up with some of your best. I think I have a Monty Python type of humor that shows up in this book. You'll let me know after you read it or whether I've ruined my medical reputation for the rest of my existence.
Okay, I'm going to report back on that one. Anyway, I'll tie this up because we have gone quiet, but we've still got lots and lots of people still have stayed in this session. So that's amazing. And as I said, everybody will have a recording over the next few days. There were just masses of questions in the chat box. And I hope that although we couldn't ask them, that when people watch back, they'll be able to pick out things that you've said. What can I say apart from a massive thank you for giving up your loads of time this evening or this afternoon for you. And, just want to say massive thank you on behalf of the UK community. It's been amazing. And I'm going to read that book.
Good. So thank you. And I appreciate it. And look, for everybody out there again, who's listening, there really is hope and more all the time. Just wait for this new publication that should be out this summer. As I said, I've just got to get my butt in gear at this point to look through these 40 to 45 charts, which there are volumes of these charts. I just need my whole office staff, and I'm going to pull my wife in on this one to get this published study, but you'll see it this year. I'll have it done this year, and you'll see some of the things I'm talking about, which is the key It's not the length of treatment. It's the dosing of these persister and biofilm forms while addressing all the MSIDS variables. That's what's going to end up being the cure. I can see it. I see what's happening with these patients. And I've been doing this long enough to know when I'm on track or not. This is where the answer is going to be.
Well, we'll all look forward to seeing the results of your study. Anyway, have a good rest of afternoon, evening.
Thank you. And to you too.
Massive thanks again.
Hey, my pleasure, everyone.
And for everybody watching, I'm going to end the session for everybody now. And thanks everybody for registering. Thank you for attending. Again, it's been amazing.
Okay.
Thank you. Good night, everybody. Good afternoon.